Welcome to Pulse&Pressors, where critical care gets crystal clear. This opening frame establishes adenosine as both a therapeutic and diagnostic instrument. It highlights the need to understand purinergic physiology, nodal microarchitecture, GI protein dynamics, potassium channel behavior, rapid drug clearance, and the mechanical physics of drug delivery. Mastery requires integrating all layers at once. A1 receptors are highly concentrated within the N and NH regions of the AV node, areas composed of slow-response cells with high resistance. Adenosine selectively depresses conduction through these regions, prolonging or blocking the AH interval while leaving the HV interval and QRS morphology largely unaffected. This region-specific effect ties anatomy directly to the ECG signature. Adenosine binds A1 receptors, activating the inhibitory GI protein. The beta-gamma subunits directly open KIR 3.1 and KIR 3.4 channels, generating rapid potassium efflux through the IKADO current. This hyperpolarization abruptly halts AV nodal conduction within milliseconds. Because it bypasses second messengers, onset is instantaneous. Clearance depends on ENT1-mediated uptake into endothelial cells and erythrocytes. Once internalized, adenosine is metabolized by adenosine deaminase into inosine or phosphorylated by adenosine kinase into AMP. Dipyridamole blocks ENT1, intensifying effects. Methylxanthines antagonize A1 receptors, requiring larger doses. Adenosine is the definitive treatment for AV node-dependent tachycardias such as atrioventricular nodal reentrant tachycardia and orthodromic atrioventricular reentrant tachycardia. These rhythms depend on the AV node for circuit completion. Therefore, nodal suppression instantly terminates the tachycardia. Adenosine's transient AV block is a diagnostic scalpel. It reveals concealed atrial activity, clarifies P-wave morphology, exposes atrial flutter or atrial tachycardia, and distinguishes SVT with aberrancy from ventricular tachycardia by observing the behavior of the tachycardia during AV nodal suppression. In stable wide complex tachycardia, adenosine provides critical insight. SVT with aberrancy often slows or terminates. VT remains unchanged. Even transient shifts in VA timing may yield EP-level mapping information. If the wide complex tachycardia continues unchanged, VT is strongly suggested. Contraindications reflect deep electrophysiology. In pre-excited atrial fibrillation, AV nodal blockade forces impulses down the accessory pathway, risking ventricular fibrillation. Transplant recipients exhibit receptor hypersensitivity and require microdosing. Dipyridamole enhances adenosine via ENT1 inhibition. Methylxanthines inhibit its receptor effect. The adult dosing sequence is 6 mg, followed by 12 mg and another 12 mg if needed. Maximum benefit occurs at approximately 18 mg. Transplant patients need 1 to 3 mg due to receptor sensitivity. Dipyridamole and carbamazepine require reduced dosing. Caffeine and theophylline require high-end doses. Pediatrics follow weight-based dosing. The Stopcock method is essential because drug delivery speed determines efficacy. A proximal IV is used. A 3-way stopcock allows simultaneous adenosine administration and immediate rapid saline flush. This method eliminates the delay caused by switching syringes and ensures the drug enters central circulation in milliseconds, preserving its effect before rapid enzymatic degradation can occur. The entire maneuver must occur in a single continuous motion while capturing ECG data at high resolution. The physics of flow determine drug success. Poiseuille's law shows resistance increases with tubing length and decreases with radius to the fourth power. Therefore, short, large-bore tubing maximizes flow. The flush must be forceful to optimize peak concentration at the AV node. The explicit goal is achieving the highest possible Cmax before the drug is metabolized. Adenosine terminates atrioventricular nodal reentrant tachycardia and orthodromic atrioventricular reentrant tachycardia rapidly. Its brief AV nodal standstill reveals atrial rhythms with clarity. Because its half-life is extremely short, hemodynamic effects resolve quickly, making it safe even in critically ill patients. When failure occurs, the expert interprets the physiology. Slow delivery, distal IV access, or receptor antagonism may explain non-response. If technique and dose are correct, failure confirms a rhythm not dependent on the AV node, such as atrial flutter, atrial tachycardia, or ventricular tachycardia. Differentiation focuses on mechanism. Junctional tachycardia does not terminate and typically shows narrow complexes with retrograde P waves. Atrial tachycardia with block reveals organized atrial activity unaffected by AV nodal suppression. Ventricular tachycardia remains unchanged because it originates below the AV node. Common effects include flushing, chest pressure, dyspnea, and a brief sense of asystole. In pre-excited AF, adenosine may precipitate VF. Transplant patients may have prolonged AV block. Bronchospasm requires beta-2 agonist treatment. These rare events demand expert readiness. Clinical mastery includes using adenosine in patients on vasopressors, interpreting its response in wide complex tachycardias, assessing conduction after ablation, and microdosing in transplant physiology. Expert interpretation transforms adenosine into a map of conduction behavior. The master clinician understands that adenosine is both therapy and diagnostic tool. Its efficacy depends on receptor density, ion channel kinetics, transporter biology, and push mechanics. Experts read the response, not just conversion, to diagnose mechanisms accurately. This is Pulse&Pressors, reflecting on the marvels of the human body. Subscribe to stay sharp.